this computer. There we go. You should get a link that I'm recording. Okay.
Okay.
All right. And I'm going to go ahead and just share my screen. We're just going to start. And Marilyn, since you're the only one on, you can totally unmute yourself. And if you have a question at any point, I'll stop where I'm at, ask the question, and we can chat about it. Okay.
Okay, that's
I
fine.
typically do that,
Can you
even if I
hear
have a
me?
larger group, but sometimes it can get too chatty and sometimes I wait to the end. But this is fall prevention and joint health. Um, and I'm Kathleen King. I have my RN, my BS, my MS. I actually also am NC, a nurse coach. So 10 years biomedical engineering experience, as well as 18 plus years as nursing. Cardiac would have been my specialty, but I did also do training across the country on glucometers. So diabetes is another specialty of mine. No financial relationships to disclose. I do have my own coaching business, but when I do these talks, they are for free. And it's really just to get general knowledge out there and hopefully get people to think a little bit about overall health and wellness. So, older adults and statistics. Older adults for this CDC slide is 65 and older. That's what they call older adults. So, every 1 second, an older adult falls. Every second of every day. That's the statistic. 1 in 4 older adults reported a fall in 2014. So 25%, 65 and older, report a fall. It is the #1 cause of hip fractures. That has been for a very long time. That number doesn't waver. Have you had a fall and not told anybody? Even if your doctor asked about it. So one, doctors don't ask a lot of times, but two, people are not normally forthcoming about a fall. Hello, Eileen. Hello, Judy. I'm glad you're here. We just started. We're only 2 slides in. But facts about falling, like why are people are embarrassed to tell a doctor they fell. Sometimes they feel like they slipped at home. Nothing was hurt, so why bother to tell anybody? But there is a reason to tell somebody because it kind of does go towards your fall risk moving forward. So 25%, we talked about this, a quarter of people over 65 are going to fall. Women are more likely to break bones. Men are more likely to die from a fall. And 95% of all hip fractures are caused by falls. We're talking about falls that are non-work related falls, right? I'm talking about falls that are not in the workplace. Every year, fall related injuries cause 800,000 patients to be hospitalized and 27,000 deaths. Okay, so falling is really kind of a big issue for us. So aside from broken hips and injured joints, why else are falls so dangerous to our health, especially to a senior's health? And here's why. It's this cycle. So here's what happens. Even if you have a fall without injury, right? So let's say you have just, you slip off the curb. The problem is it does generate a fear of falling again for a lot of people. And that fear of falling, unfortunately, leads to less activity for many. Less activity leads to decreased muscle strength and balance. And decreased muscle strength and balance leads to, you got it, increased risk of falling. So we do create this cycle where somebody who has had a fall is actually more likely to fall again, in part because they start to protect themselves a little bit. So that becomes a vicious cycle for them. So what actually puts individuals at risk for falls outside of the workplace? Again, I wanted to focus on outside of the workplace because workplace falls are just a different animal. So intrinsic is individual factors, factors that have to do with yourself, your body, your own being. Environmental factors or extrinsic, those are things that have to do with the environment. So in terms of individual risk factors, balance, gait, or mobility problems. That's number one, because what happens a lot of times as we age, and I am included in this, I'm 56 going on 57. When my hip is hurting, I change how I walk. When I change how I walk, I have affected my balance, my gait. And as I do that, I start to use different muscles, I weaken other muscles, and I throw my balance off. When I throw my balance off, that makes me a candidate for a fall, right? So in terms of individual risk factors, balance, gait, mobility problems due to degenerative joint disease, also things such as you've had a stroke in the past or Parkinson's, you might be diagnosed with Parkinson's or another movement disorder, MS, that would certainly put you at risk. Visual impairment, that's not corrected, right? So you have glasses, you wear them, that's not a visual impairment. You have glasses, you don't wear them, that's a visual impairment. Impaired cognition or depression, that's just an increased risk factor. Postural hypotension means when you stand up, you have a decrease in your blood pressure. So normally people who know they have postural hypotension are asked to stand, count to 3 before they start moving. If they don't do that, they are at risk of falling. And anybody at all taking more than 4 medicines are at greater risk to fall. That has been proven with studies over time, almost irregardless of what those medicines are. But we do know that centrally sedating or blood pressure lowering medicines put you at a higher risk. Environmental factors. So indoor hazards, slippery floors, rugs, carpets, poor lighting, your shoes, the quality of your shoes, bathroom fixtures, the height of a chair or a bed, unstable furniture. You put your hand on it and it falls over. That's not, that does it, put you at risk for a fall. Stairways. Do you have a railing? Do you always use the railing? And outdoor hazards, uneven pavement is an issue. Uneven ground is an issue if you're walking through your backyard. Steps, snow, ice, rain, anything like that, those are all going to be risk factors. And given the intrinsic and extrinsic, hold on. All right, I see the knee replacement. I will talk about that in just a little bit, okay? But I see it in the chat. Okay. Given the intrinsic and extrinsic risk factors, it is clear why seniors are a little more at risk for falls outside of the workplace. Seniors tend to have a little more medication on board. Seniors tend to have more degenerative joint disease. So that's kind of why we're a little focused on seniors when we talk about fall risks. So let's talk about these environmental ones, and let's think in your head walking through your own apartment, right? Or your own house. So one, loose rugs or throw rugs. Flooring that's pulling up, right? That you could trip over. Tile that's slippery. We have a hot tub, and I'm telling you, there was a tile floor out there, and my children slipped on that tile floor endlessly. So we had to change the flooring. Poor lighting. Uneven surfaces, like when you go from a tiled kitchen to a carpeted living room, or a floor to tile or a floor to carpet. Anytime you have a change in surface, you might have an uneven transfer. Stairs, are they carpeted or hardwood? Does that make them slippery? A bed that's too high or too low. The reason we say that is sometimes if it's too high, as you go to get off it, if your feet aren't firmly on the ground, you push a little too hard and you go, flying forward. How about your yard, your car, or the places you walk? Do you have to worry about rain, snow, or ice to get to your car? Like if you're in the garage, maybe not at all. But if it's in a driveway and you don't have a garage, you might have a problem. Are your sidewalks uneven? Like, would you be better off walking on a paved path, like a bike path, as opposed to your neighborhood streets? Do you have steps to maneuver in or out of your home? One, is there a railing? And two, do you use it? I have to say I've gotten accustomed to actually grabbing the railing now. And just because I'm like, you know what, if I slip, at least if I'm holding the railing, I've got a shot. And is outside lighting. Lighting, people underestimate how much lighting helps. I have an Airbnb and I actually do have lighting that comes on at dusk because I'm worried about people falling. Reducing intrinsic. So this is actually fall risks that have to do with, again, your personal kind of profile. So staying physically active, specifically working on strength and balance. If I came up to you and you were standing and you didn't expect me to, and I bumped you from the side, can you right yourself? Right? So if somebody comes up and bumps me from the side, can I straighten myself? Can I right myself? Can you get up from a chair and sit back down without the use of your arms? Everybody should be able to do that. I have my Parkinson's patient practice that. That is a big deal for balance and for strength. Do you look ahead when you walk? Like, do you look straight ahead or are you looking down at your feet? Looking straight ahead is what improves our balance. Do you practice good posture? Seniors do not naturally get shorter and hunched over. That is not a natural aging process. It happens, and a lot of people let it happen a lot, but that is not part of normal aging. Adding posture back, shoulders back, length to your neck and to your spine is really important. And again, that actually helps with both balance and strength. Do you have corrected vision or hearing? And are you good about wearing your glasses or hearing aids? I know plenty of people with hearing aids, but they do not wear them. That's not helpful. And then we go to this other side, medications. So we bring up medications because people sometimes forget that taking medications do make you a fall risk. They just do. How many medications you take? Do you know what their side effects are? Do they have the potential to cause dizziness, lightheadedness, or orthostatic hypotension, that low pressure as you stand up? So um, reviewing your medication with a trusted family member or friend, right? Like go through your list, see what you're taking, right? Are you taking it exactly as it's prescribed? You'd be surprised. A lot of times we're not. Like, maybe it says to take it at night, but you take it in the morning. Well, is there a reason that it's asked to be taken at night? Because some do have sedating properties. So maybe that's why they want them taken at night. Now, maybe you take them during the day and you don't have any problem. That's great. But it's a good practice to go through and double check your prescriptions. If you have any questions, I think people underestimate how good a pharmacist can be. I know it's tough for us to reach our doctors sometimes, especially on the Cape, but and our pharmacists are getting there too. But a pharmacist can review questions with medications and dosage instructions very well. They are medical doctors. They know their stuff, especially when it comes to medications. So pharmacists can be very, very helpful in this arena. And otherwise, if you have concerns about side effects of any of your medications, or maybe you're taking two medications and you think they kind of do the same thing, and you wonder, do I really need to take both of these? That's something to review with your doctor, either next time you go in or make an appointment just to go over medications. These are exercises that you can do to improve your balance. This entire presentation, oh my, yes, I did tape it. This entire presentation will be available on the YouTube channel, so you can actually go to it and stop right here if you want to do these exercises. So there's 4 exercises. One is lifting your leg behind you while you hold onto a chair. One is standing up on your tippy toes. One is lifting a leg in front of you, knees up. And one is actually with a long leg, swinging it back like a pendulum behind you. Now, if you notice, if you want to do a balance exercise, you're going to do it slowly. You're going to hold each position for 1 second. Repeat it 8 to 15 times. And you can hold on to the chair with one hand for balance if you need to. But the goal would be that as you advance, you would try it with no hands. And then, if you really advance, with your eyes closed. So the one that you might be able to do with your eyes closed almost initially is up on your tippy toes. You might be surprised. I bet that most of the people who watch my webinars could probably do the closed eye, stand on your tippy toes and come back down. Because I think your balance is probably not as bad as you think, but it might depend on how your joints are. And these are medications. I just want to show you different kinds of medications and how they would increase your risk of fall. Diuretics would be things like Lasix, furosemide, torsemide. Sleeping pills of any kind, even if they're over the counter, even if it's, melatonin or sleepies or something, it's still going to increase your risk because it's something that's actually promoting a little deeper sleep. So whenever we're promoting a little deeper sleep, it's going to increase the risk that as you're, waking in the middle of the night to go to the bathroom, you might be overtired. Antipsychotics. I put them there because a lot of people don't realize it, but we use antipsychotics for off-label reasons for a lot of things. I'm taking one myself right now because I have a concussion that I'm getting over. So it's not because I need an antipsychotic per se, because I'm psychotic, but we use this medication. So again, that increases the risk. Antidepressants, opioids, probably everybody knew about opioids. So clearly if we're taking painkillers, that would be an issue. But again, look at polypharm. So polypharm is 4 or more medications. If you're taking 4 or more medications, 75% increased risk of a fall. Again, well proven with studies. All right, so I know I'm moving fast as lightning because it's a very fast talk, but joints. As we age, so do our joints. But there's really only one joint that is most affected by our balance and strength, the one that gets most injured in falls, and that's the hip joint. And I wanted to show it to people because not everybody, I think, can visualize a hip. So this is what the hip looks like on one side. So you have that pelvic bone that's kind of your sitting bone, right? That encompasses what we call the hip. That's really what we call the hip when we're talking about pelvis bone. And then you have the femur. And the femur is your long leg bone. And at the top of it, that femoral head is basically a ball. It's a round ball. So if this was the femur, here's the round ball. And this comes into the socket. And that's why we can do this, right? So it moves like this. And a lot of our breaks actually happen close to that femoral head. So watch. So the non-displaced intracapsular hip fracture, that's going to be right at the ball, the head of the ball is what we call it, right? The non-displaced extracapsular trochanter fracture, we get a lot of those too, a trochanter fracture, if you've ever heard it. And then there's a subtrochanter fracture, which actually is a fracture really of the femur, but because of where it's located, they're going to end up doing a hip replacement. Sometimes it's a partial hip replacement, sometimes it's a full hip replacement, but they're going to replace that hip. That's going to be the goal. Okay. And here, that's what it looks like. So the pelvis stays intact. They shave a little out. They kind of sandpaper it. So some new bone will grow. And then you have the receptacle that picks up the head of the new femur. And if you notice, there's this metal ball that kind of goes down into the bone of the femur. And what's nice is the bone grows around all of this metal. And usually they use a cement to put this in place so you can stand on your new hip the day after you get it, which is actually really, really good. Falling in ways that cause injuries not associated with your hip joint, like if you fell up the stairs, unfortunately, if you look at this, this is going to end up being a shoulder or an arm, right? So the other common areas around joints that get injured in falls that could necessitate a knee or a shoulder replacement is a humerus fracture. So that's the upper arm. Honestly, if it's down far enough, we don't do anything. We kind of splint you and it just has to heal on its own. They normally a lot of bruising, very purple. It's a very painful fracture, actually. But if it's up high enough into the joint, you might be looking at a shoulder replacement. Knee, the same thing. If it's these two lower leg bones, the tibia and the fibula, sometimes they refer to it as a tib-fib fracture. So you break both bones in that lower leg. If it's a tib-fib fracture, they might just put you in a boot and say you're fine. But if you end up with a fracture up near the patella or right inside the knee joint, like, so if you have a fibular or a tibia fracture inside the knee joint, they may actually suggest that you get a knee replacement with that fracture. Depends on positioning. So aside from I've fallen and I've hurt my joints, how can I keep my joints healthy? So for those of you who are contemplating joint replacement or maybe are trying to put off joint replacement, here are 15 best foods for your joints. We are always trying to lubricate our joints. We're always trying to, keep the cartilage moist and pliable. We want to build flexibility. So fatty fish is great. Dark green leafy vegetables, you guys would know about that. Olive oil, walnuts, spinach, berries, broccoli, green tea, garlic, ginger, grapes, turmeric, kind of good for everything, and ginger. These are, just great for joints. They're good for osteoarthritis. They're lower in inflammatory markers, so you'll get less inflammation in your joints. And other ways to protect your joints. If you're a smoker, quit. I want to go back to that. So 1 second. If you're a smoker, quit. So if you're going in for a replacement and you've been a smoker, we want you to quit, or you don't smoke while your joint's healing. It causes inflammation and it makes it harder for your body to heal. You're not going to get a great result with that joint. 2, replace energy drinks and soda with water. That's any soda. So even if it's seltzer, water is better. Your cartilage is 80% water, and that's the joint's cushioning system. Whenever we can get extra water into you, it's better, and water, it would be the number one choice. Non-carbonation is the number one choice. 3, don't let extra pounds overtax your joints. This is so hard. This is really so hard even for me. So 10 extra pounds on your body creates an additional 20 to 40 pounds of force on each knee. So that means you take 10 pounds off, you can potentially decrease your knee, the pressure on your knee by 40 pounds of force. That's a lot, right? So sometimes we have to just sometimes think about, can we try to pull off a few extra pounds? 4, always warm up and cool down. So even if you're going to go for a walk, stretch out a little bit. Don't go hard into anything. If you're going to do a workout class, a Zumba class, stretch first, stretch after. Don't go running outside into the cold and get in your car. It's not great. It can be very protective to warm up and cool down. And listen to your body's cues. If you have joint pain that persists for more than a few weeks, it's worth bringing it to your doctor, because if you start changing your gait, if you start changing how you walk or upsetting your balance, you're going to significantly increase your risk of fall. And so now, instead of treating a sore hip, you might be looking at a hip replacement in an acute situation where there's a break. That's never good. All right, so prevent falls. We've talked about all this stuff before, right? So make an appointment with your healthcare provider, right? Get regular checkups, check your medication list. Do you need them all? And if they ask if you've fallen in the past year and you have, please be honest. Let them know. Keep moving, regular exercise. Walk at least 30 minutes a day, even if it's 10 minutes at a time. Okay, and work on your balance. Wear good shoes that fit, right? No flip-flops. Please, no flip-flops. Remove tripping hazards in your home. If you have throw rugs, pull them up or tape them down, right? Any table legs or end tables that are in the way of a main walking area, push them up against the wall or somehow get them out of the walking area. Electrical cords, the same thing. Please make sure they're out of any walking areas. Improve lighting if you can. They're really cheap. You can get plug-in lights from Walmart, from Amazon. You plug them in, they come on when it's dusk, and they just light. It can be low-level lighting at your feet just for night. And assistive devices. So having handrails for steps and walkways, having grab bars in the bathroom, use things that you need. It is not a sign of weakness to use grab bars. And I've added a couple of these slides because my own mom is turning 89 tomorrow. And I'm telling you, this is where I can't even tell you. Slow down, calm down, don't worry, don't hurry. Seniors that are anxious and hurrying for any reason. Everybody's waiting in the car. I better hurry up. I have to go to the bathroom, and otherwise I'm going to wet myself. I can't tell you the hurrying to for people's convenience or for some other reason is so scary to me, because that's really when people fall. They, when you're worried about inconveniencing other people, you're not thinking about what is the safest thing for you. Okay. So please, it's worth the extra minute to just take it slow. The other thing a lot of people don't know, if you have a fall in the home or a near fall, Medicare actually would make you eligible for physical therapy. If you tell your doctor you had a near fall or fall in the home, you're eligible for a physical therapy evaluation. And if they find you're deficient in balance or strength, you will qualify for physical therapy sessions. So do it. It's great. It's a great way to up your strength. And for whoever just said they're getting a knee replacement, I'm hoping you're already doing physical therapy pre knee replacement, so you will be in prime shape for after, but we'll talk about that in a minute. And then the last thing, I saw this last year in 2022. This to me is fantastic piece of information. So they did this pretty big study, and they were trying to figure out, could we put something in a regular physical that would show doctors, that would give an indication of people's overall general health. And they honestly concluded that people who failed a 10-second balance test of standing on one foot were nearly twice as likely to die in the next 10 years. And they're not saying it's because you can't stand on your foot. That what they're saying is that piece of information somehow is an indicator of your overall health, whether it's that there's obesity or imbalance or, or a chronic disease like Parkinson's or a past stroke. But the people who can't do this, here's what they figured out. The people who can't do this were nearly twice as likely to die in the next 10 years. And so what they're talking about is, should adults 55 and older be asked in a physical to stand on one foot for 10 seconds and then stand on the other foot for 10 seconds? It's a really good question. And I think I'd like to see it added to physicals. I think it would be a really good idea, but that's just me. So thank you. I know that was a whirlwind, and now we can really have a chat about lots of things, but I think most of you know what I do. If you don't know what I do, like I said, I'm a nurse coach. I do medical advocacy for people. I also do case management and care transitions for families. I'm available to help in any capacity. If you need some help trying to get your health up. All right. So Marilyn, you have knee replacement in December, and you're worried about falling during the recovery process. That is a fair concern. Are you coming straight home after the knee replacement, or are you going to rehab?
I'm coming straight home. Can
you
you
going
hear me?
Straight home?
Yeah.
I can. I'm gonna up it a little bit because I can't hear you that well.
All
right. Say it again. You're going straight home?
Yeah, straight home. It's just outpatient surgery,
Yeah. Right. So did you consult with them about what you should have at home in terms of grab things. And, I'm assuming they're going to want you to use a walker for a little bit.
My understanding is that you use a walker for about a week and then you use a cane. Or
Yeah.
I'll just
So,
put my video on and there.
right.
So yeah, you use a walker for a little while and then cane. I have been reading on Facebook all these horrible stories of people falling, and it's just terrifying. So I don't know if I think your talk has been very helpful. So I appreciate that.
Well, so some of it, I think, Marilyn, is exactly what we talked about, like just those checklist things. So if you have throw rugs and stuff, get rid of them before the surgery. This is one of those times the in and out of the shower is got to be that's going to really be the challenge. Um, I would recommend a shower chair for a little bit.
I have one because my husband had he had a fall last year, so we've gotten all that stuff. So I feel like I have it. I just wanted to check in and see if there was anything else.
Yeah. No, but I usually we're most worried about people who aren't worried about falling. So here, the people who fall, Marilyn, are typically the people who are like, I got this. I don't have to worry about it. And they move a little faster than they should.
Yeah.
That little bit of fear is actually a good thing. It will slow you down a little bit. It'll cause you, like when you get up, like take a good look. Like, how close am I to things? Where am I going? And certainly you're going to be using pain, you're going to need pain management. And I would strongly encourage ice, and more ice.
Yeah. Yeah, that's my understanding. I
Now
don't want to give too much pain medication, but
well, it is one of the most painful joint replacements.
yeah, I know.
It just is.
That's what I've heard.
Right. Yeah, and so for a little while it's going to be miserable. You know what I mean? Like it just is. That's the truth. And I think when people are prepared for that, then then you're prepared for that. And it's okay, because in the weeks and months after that, it'll all be worth it. If you talk to people who had it done, they love their new knees. They do. Everybody loves their new knee. It's just the process is hard,
Yeah.
right?
Mm-hmm.
And
yes,
where are you getting it done?
Cape Cod Hospital.
Nice. Okay. So staying close to home.
Yes. I just didn't want to go to Boston because then your doctor is pretty far away if you need him.
I know. No. That's good. That's good. All right. Do you have any other questions? Oh, wait. I had a question. So are you in physical therapy? Are you doing therapy now, pre-knee?
I started doing therapy, and then my therapist broke her wrist. And so they canceled the therapy. And then they said it would be better if I used the therapy that's allowed me after the surgery rather than before, because I had actually switched doctors. So one doctor wanted a certain amount of therapy before, and one doctor, I've been in therapy kind of since last September when my knee really started to hurt. So I just said, okay, I belong to a gym. I can do the bicycle and stuff. And maybe it's best to have that more therapy after.
So the deal is, you probably know then the things you can do to strengthen the muscles around your knee.
I do. I don't do them as much as I should, but I will now.
I know. So what you need is a buddy to help you to make sure that you get those done. No, really, because I will tell you, most of the doctors I know that do these replacements prefer, even my mother who had a shoulder replacement, they much prefer people to have therapy, to be doing exercises to strengthen everything as much as they can before the surgery, because it's just going to help you on the back end. So it's probably still worth doing a lot of those exercises, even if you have to do them on your own at home.
Yeah, and I think I've got, I have the sheets of paper telling me
Yeah,
what to
sure.
do. Um,
Right.
I'll
And
add
they're
the
right. That
yeah,
does preserve more therapy days for after the surgery from an
yeah,
insurance standpoint. So that's good.
yeah. So that's what she was saying. So it'll all be fine. It's just that
Yeah.
it's comforting to have someone help you through it.
Yeah, yeah. No, I understand that. No, I understand that.
Yeah.
So that's good. And Eileen, how about you? Did you have any have you had joint replacement of any kind? You're still muted. Maybe not. All right. Well, do you have anything else, Marilyn?
No, but I just want to say I just came across this notice for this today, and I really appreciate your being here, and I like your presentation and uh, your attitude. I found it very
Yes.
helpful, and thank you very much.
Oh, good. So I do them about once a month. I don't think I'm going to do one in December. But I do have this YouTube channel. So my name is I go by Reliable RN.
Okay,
And that's my business. And so you could actually go back and even like, just watch to a screenshot. Like if you just wanted to see one, you're like, oh, I really wanted to go back and look at that one slide she did. If you go to the YouTube channel, you can hone in on just that one slide once I post this.
I
Okay.
actually took a screenshot of the ones that I was interested in.
Oh, there you go.
Yeah,
You're already doing it.
yeah, already doing it. So,
All
yeah, I
right.
appreciate it. Great to
Well,
meet you.
thank you for tuning in.
Thank you for doing this for me.
All right. I'll talk to you soon.
All right, bye bye.
Bye bye.